Hi, everybody. Thank you so much for joining us today. We're going to be looking at understanding diabetic eye disease, and we're very fortunate to be joined by Associate Professor Peter Van Wijngaarden from the Centre for Eye Research Australia. My name is Delaney, and I'm part of the Program and Services team at the Macular Disease Foundation Australia, and I'll be facilitating today's webinar. Before we move on, I would like to acknowledge the traditional custodians of the land on which we are meeting today and pay my respects to elders past, present and emerging. I'd like to welcome you today to today's webinar, which is going to be all about understanding diabetic eye disease with Associate Professor Peter Van Wijngaarden. We have him here today. Thank you so much for joining us. Associate Professor Peter Van Wijngaarden is the Deputy Director of the Centre for Eye Research Australia and Associate Professor of Ophthalmology at the University of Melbourne. He's a founding committee member and clinical director of KeepSight, a national program for diabetic retinopathy screening that seeks to reach every Australian with diabetes to prevent avoidable blindness. Associate Professor Peter Van Wijngaarden is the Director of the Ophthalmic Research Institute of Australia and a member of the Research and Medical Committees of the Macular Disease Foundation Australia. He's also a member of the Australian Alliance for Artificial Intelligence in the Healthcare Workforce Program Committee and the Future of Ophthalmology Task Force for the Royal Australian and New Zealand College of Ophthalmologists. So thank you so much, Peter, for joining us today, and I can't wait to hear your presentation.
Thanks, Delaney. It's my great privilege to be speaking today. I'm just going to share my screen, so forgive the brief interruption. Just confirming that you can see that okay, Delaney?
Yes, that's all perfect. Yes, all good.
Fantastic. So it's my great privilege to join you today for this webinar, speaking about diabetic eye disease, which is something that I'm really passionate about making a difference to. I'd also like to acknowledge country. So I'm speaking to you from the lands of the Wurundjeri people, and I'd like to pay my respects to their elders past, present and emerging. So as Delaney mentioned, I'm a member of the medical and research committees of the Macular Disease Foundation, and I'd just like to state at the outset what a tremendous organisation MDFA is. Really do such a remarkable job to advocate for people with macular disease in Australia and making sure that we have the very best options for treatment and prevention of avoidable blindness. So it's a great privilege to speak at this forum. So today, I'll just begin with an overview of what we hope to cover during the next 40 minutes or so. So we'll provide a brief overview of the anatomy of the eye so that you understand the various parts that we're talking about. We'll provide an overview of what diabetic eye disease is, how common it is, what the risk factors are for the disease and how those risks can be reduced. We'll talk a bit about the symptoms of the disease and how it's treated. I'll then tell you a bit about KeepSight, a program to prevent avoidable blindness from diabetes. We'll address some common concerns and misconceptions, and then I'll point you in the direction of where you might be able to get more help or learn more. And if we have time, we'll have some questions from the audience. So I'd encourage you to add those to the Q&A section, and we'll do our best to address those at the end. So with no further ado, here's a cartoon depiction of the eye. So you can imagine if we were to slice an eye in half, this is what we'd see. So you can see the left side of the image, the clear window of the eye, which is the cornea. So light entering the eye passes through the cornea, and then passes through the pupil, which is the black hole in the middle of the coloured part of the eye, which is known as the iris. So light passing through the cornea, through the pupil, then goes through the lens, which is that glassy looking object in the middle. And that helps to focus the incoming light on the retina of the eye, which is the wallpaper that lines the inner aspect of the eye. It's a really delicate tissue, and it's made up of nerve cells which transmit the signals of, or the light. They convert the light signals into electrical impulses, which are then travel down delicate cables known as axons or nerve fibers, all the way to the visual centers of the brain. So it's the retina that's affected in diabetic eye disease. And the retina is really this remarkable tissue. So it does this job of detecting and processing those light signals, and that requires a tremendous amount of energy. It requires oxygen and nutrients to be in constant supply. And so you can see in that cartoon that there are lots of little blood vessels running on the surface of the retina and just in the inner retina itself. So those blood vessels are really, really crucial in delivering that constant supply of nutrients and oxygen. And we're going to learn a bit about why disruption to that blood supply in diabetic eye disease causes troubles. So the main things that can occur in diabetic eye disease are retinopathy, which is the changes in the retina. But we also see in many people with diabetes the formation of cataract. So cataract is a clouding of the natural lens in the eye, that object in the eye that focuses light on the back of the eye. So you can see that that's depicted there as a slight clouding of that lens. Now, we all get cataract as we age, but the process is accelerated a bit in diabetes. The good news is that we have excellent surgical options for cataract. So usually that's done as a day procedure, and people experience a significant improvement in vision after that surgery. The only caveat is that for people with diabetic eye disease, particularly if they have quite advanced retinopathy, we need to, as eye doctors, manage that retinopathy before we do the cataract surgery, because cataract surgery in the presence of retinopathy can lead to poorer visual outcomes. So that's just something to remember, that if you have diabetic eye disease and you get a cataract, it's important to know that the retinopathy has been optimally treated. So retinopathy, to understand that, we'll go to some photos of the retina. So this is what I would see when I am in my clinic and examining patients. And this is a nice, healthy retina. So it's a photograph of the inside of the eye, and you see that beautiful reddish orange glow of a healthy retina. You see the yellowish disc just to the right of center, and that's the optic nerve. And you can see little red lines emerging from the optic nerve. Those are the delicate blood vessels on the inside of the eye. So that's a nice healthy retina. Here is an example of a retina with someone with moderate to severe diabetic retinopathy. And you'll notice immediately that there are quite significant differences in the appearance. You can see some reddish streaks, which are small amounts of bleeding within the retina itself. And you can also see some yellow specks. And that's where the blood vessels in diabetes become a bit leaky. So not only do they bleed, but they can also leak the fluid component of the blood, which contains fats and proteins. And over time, those form little accumulations within the retina, which can then block the vision. So that's some of the changes that occur in diabetic retinopathy over many, many months to years. So we get leakage, we get bleeding, but we also get blockage of the very delicate blood vessels at the back of the eye. In response to that, the retina produces a chemical which makes blood vessels grow. And that chemical is known as vascular endothelial growth factor, or VEGF. So you would think that's quite a helpful thing, that the retina, when it's starved of oxygen, produces a chemical that makes blood vessels grow. But unfortunately, it doesn't typically, those blood vessels don't typically grow in a healthy manner. So instead of growing within the retina itself to supply the retina with more oxygen and nutrients, it tends to grow away from the retina into the front parts of the eye, into the jelly bag, which sits in front of the retina. And so what you can think of is that these blood vessels protrude from the back of the eye, a bit like seaweed growing up from the seabed. And as the eye moves, those sort of fronds of blood vessels move about, and they're quite vulnerable to breaking and bleeding. And so then you can get bleeding into the jelly in front of the eye, into the vitreous. It's what we call a vitreous humor. And you can see that depicted there on the left image. So that tends to be quite a late complication of diabetic retinopathy that would either be managed conservatively, so that person's vision would be blurred for many, many months as the blood gradually clears away. or it may be an indication for an operation to clear that blood away from the inside of the eye. We know that blood vessels that form in this way also develop together with some scar tissue, and you can see that in the right side of the image. So that scar tissue protrudes away from the back of the eye, and the problem with scar tissue is that over time it tends to contract. And as it contracts, it can put tension on the retina at the back of the eye and begin to pull that away from the back wall of the eye, which can lead to permanent reduction in vision. So those are more advanced changes. And the reason that I think it's important that we address those is that that's what we're trying to avoid through early detection of diabetic eye disease, because we know if we treat people at this very early stage or at the beginning of the development of these abnormal blood vessels, we know we can achieve good long-term outcomes in most cases. So we've spoken about cataract, we've spoken about diabetic retinopathy, but there's another type of diabetic eye disease that's important for us to know about, and that's diabetic macular edema. Macula is the region in the center of the retina, and it's demarcated there with that dashed yellow line. And that's the region that's specialized in our retina for detailed vision. So when we look at an object, if we're reading or looking at someone's face or very fine details, we move our eyes so that we focus our macula on the object that we're interested in. So it's the most detailed part of our vision. And the very center of the macula is called the fovea. So it's this specialized region of the retina that's involved in macular edema. And edema literally means swelling. So small blood vessels in diabetic eye disease can gradually leak, and very small amounts of fluid can collect within that macular region. And that can cause a distortion of the nerve cells and cause blurring of the vision. So I'll just go back. So here we have that example in the left image of a nice healthy retina. And on the right, we can see that there are some significant differences in this person who's got diabetic macular edema. You can see that there are patchy hemorrhages, so little spots of blood in the central area of the retina. And you can also see those yellowish patches, and that's fats and proteins that have gradually leaked out with the fluid from those blood vessels and formed little concentrations. And those concentrations of fats and lipids are what we call hard exudates, and they can obscure the vision. So this person's likely to have quite poor vision due to diabetic macular edema. Now, when we see people in our clinics, we not only do we take photographs, but we also perform another type of imaging called optical coherence tomography, or OCT for short. The left image shows you a nice healthy retina. You can see the photograph, and then you can see the OCT image. And the way to think about OCT is a bit like an ultrasound that a pregnant woman might have to see the baby inside the uterus. An OCT, instead of using sound waves as is used in ultrasound, the OCT uses light waves, and it provides a cross-sectional image through the retina at any given point. So that scan that we see bottom left is a scan through the macula of a healthy person without diabetic macular edema. And you can see that there's this little dip or concavity, and that's the fovea. So that's the very most specialized region for central vision. So that's that normal dip that we expect to see. If we look across to the right images, you can see the photograph shows this sort of stippled yellow patterning in the macula, which is the leakage of fats and proteins, or exudates. And if we look at the OCT below, so bottom right, you can see that the picture is quite different from the one bottom left. So instead of having that very organized, almost layered structure, you can see that it's a bit disorganized, and you get a loss of that central depression. Instead of being a concavity, it's convexity. And you can see these black fluid-filled cysts. That's actually water that's leaked out of blood vessels and is accumulating in the retina. So you can imagine that that would cause some blurring of the vision. And so that's the common symptom that we see in people with macular edema, is blurring of the central vision. So after that, that brief introduction into what diabetic eye disease is, I thought we'd reflect a little bit on how common diabetic retinopathy is. We know if we look at a number of population studies of people with diabetes, that about 1/3 of those people at any one time will have some degree of diabetic retinopathy. Fortunately, for most, it's quite mild. It's mild to moderate disease, but it is sight threatening in about 5 to 10% of people. So when you think about how common diabetes is and the population size of Australia, it's likely that there's an MCG equivalent number of people, so a capacity crowd at the MCG, or about 100,000 Australians with sight-threatening diabetic retinopathy at the moment in Australia. So a significant number. We know that about 70 to 80,000 people with diabetes have some degree of diabetic macular edema, and that's sight-threatening in about half of those people. So it's a significant problem. So we've heard some, quite alarming statistics, and we've seen some rather graphic photographs, but I can reassure you that the vast majority of vision loss and blindness from diabetes is avoidable or preventable. So that's an important take-home message, that there really is a tremendous amount that can be done to reduce the risk of vision loss and blindness from diabetes. So how do we do that? So to understand how to reduce our risk, it's important to know about the risk factors for diabetic retinopathy. There are some that are not modifiable, and they include the duration of time that you've had diabetes. We know that people who had diabetes for longer are at higher risk of complications, including diabetic retinopathy. We know that the risk actually increases quite steeply after around about 15 years of having had diabetes. There is one little caveat to that number though, in that many people who are diagnosed with type 2 diabetes have often had diabetes in the background for many years before the diagnosis is made. And so we do know that when we examine the retinas of people with type 2 diabetes at the time of diagnosis, a significant proportion have some degree of retinopathy already. So that's important to bear in mind. So we've spoken about duration of diabetes. We also know that people who have other complications associated with diabetes, like foot ulcers or kidney disease, are also at higher risk. And so we need to watch them a little bit more closely. So those are the non-modifiable risk factors. But what about the modifiable risk factors? Well, there's really strong evidence that if you are able to keep your blood glucose, your blood pressure, and your blood cholesterol within target range, you dramatically reduce your risk of developing diabetic retinopathy. And if you already have diabetic retinopathy, control of sugar, of blood pressure, and cholesterol can also reduce the risk of progression of disease. So those are really important. Smoking is, of course, not good for eye health in general. And so it's generally recommended that if you have diabetes, smoking cessation should be a target. The only two graphs that I'll show during the webinar today, just to bring home those points. The first shows the risk of severe diabetic retinopathy as a function of duration of disease. And you can see that those curves really start to kick up at around about 15 years after the onset of diabetes. So that does tend to be a bit of a turning point where we recommend people start having annual eye checks, so eye checks every year. The second graph shows us the great relationship between how well blood glucose is managed and the risk of complications. So diabetic retinopathy is the blue curve at the top. And so you can see that the further the blood sugar level is away from target, which in this case is 7% on the HbA1c scale, the higher the risk, and it starts to increase quite dramatically. So we've spoken about reducing risk of diabetic retinopathy through controlling those risk factors. But another way of managing the risk is by having regular eye checks. It's recommended that everyone with diabetes has eye checks at least every 2 years. Most of those diabetes eye checks are performed by eye care providers, and so that's optometrists and ophthalmologists. Some general practitioners and diabetes specialists do perform diabetes eye checks, but it is a minority. The vast majority of these routine diabetes eye checks are performed by optometrists. So we've mentioned every 2 years is the recommended interval. The caveats to that are that yearly eye checks are recommended for people who've had diabetes for 15 years or longer, people who have other complications of diabetes, or people who are from an Aboriginal or Torres Strait Islander background, because we know that Aboriginal and Torres Strait Islander people are more likely to get diabetic retinopathy. So annual checks are recommended for those groups. Of course, if you've got existing diabetic retinopathy, you'll need to have eye checks more frequently, and that will be guided by your eye care provider. And in some cases, if you're having treatment for diabetic retinopathy, it might be as often as every month. There are a couple of special circumstances where more frequent examination is recommended, and pregnancy is one. So any woman who has diabetes before becoming pregnant should have an eye check during the first trimester of pregnancy, and then frequently during the course of pregnancy. So what constitutes a diabetes eye check? Well, the three basic elements of an eye check are a test of the vision, and the vision should be tested in each eye separately. There should be an examination of the eye, and that's often done at what we call a slit lamp. So you can see that there in the middle image. It's basically using a microscope to have a careful look at the eye. And then the third element is a photograph of the retina of the eye. And that's really important as a historical record. So we get very detailed information in a photograph that in a few years' time, when you have your next exam, we can compare and we can see if there's been any progression of the retinopathy. That highlights one point that I'd like to stress. It is always best to have your eye checks by the same eye care provider, so going to the same clinic, because they have that opportunity to look back at your last images to see if anything's changed. Of course, going and seeking any eye care provider is better than none, but if we're talking about what's optimal, it's always best to develop a relationship with your optometrist or ophthalmologist. So we mentioned that some people will need to go on to have an OCT, that cross-sectional imaging, and that's particularly done if your optometrist or ophthalmologist thinks that you might have macular edema. But there's another test that might also be performed, and particularly if it's thought that you might need treatment for your diabetic retinopathy, and that's an angiogram. So in an angiogram, we inject a very small amount of brightly coloured dye. You can see that at the bottom of the screen there. That's injected into a vein in the arm by an ophthalmologist, and that travels through the circulation and into the blood vessels of the eye. And as it's passing through those blood vessels of the eye, photographs are taken, usually with a bright blue light flash on a specialized camera, and we can watch the dye which fluoresces under that blue light as it passes through those blood vessels. So I've got some illustrative examples in the next slide. So here you can see a retinal photograph before the dye has appeared. You can see the blood vessels look like dark squiggles there in the image. Here you can see the dye's just started to pass through the retinal blood vessels. You can see that the arteries look bright white and the veins look a little bit darker. And you'll also notice that there's a region at the top of the image where you see little stipples of bright fluorescence, or those bright little dots. And that's where we start getting dilation of the blood vessels in diabetes, what we call microaneurysms. Around those microaneurysms, they're little sort of darker spots, and that's where the really fine blood vessels, the capillaries, have become blocked. And so that's an area where the retinopathy is starting to progress. We can also see it sort of has a hazy type appearance, almost like ground glass, and that's where the dye is starting to leak from those little damaged blood vessels. Here's a later phase photograph. So now the major arteries and veins don't stand out as much, but what we can see is that those aneurysms that we spoke about start to stain, and we can see that there's a hazy appearance to the tissue in that area, and that's because the dye has leaked out into the retina. So that's a very useful test that often guides the management of people with diabetes and diabetic retinopathy. So we've covered what constitutes an eye exam. What are the symptoms? And I think this is a really important take-home message. In many instances, diabetic eye disease can progress to an advanced stage without any symptoms at all. And when the disease is really advanced, we know that treatment becomes more difficult, more prolonged, and outcomes can be poorer. So regular eye checks are really important. You shouldn't wait until your vision's affected by diabetes before seeking out an eye check. So having a regular schedule of eye exams will make sure that you can detect the disease at a time when treatment has the best possibility of a good outcome. That being said, we do know that in many cases, macular edema causes symptomatic blurring of vision. So that might just be a hazy or difficulty seeing, say, the television or reading a book. But it may not be noticed, particularly if one eye it has good vision. So if the macular edema is only affecting one eye and it comes on gradually, often we find that people may not notice. And the first time they notice is perhaps when they've covered the better seeing eye. Bleeding into the front of the in front of the retina, what we call vitreous hemorrhage, often presents with things floating past the vision. Usually they have a darkish color. Sometimes people describe a reddish or a brown hue to those floaters, so different from the little occasional floaters that many of us experience. This is floaters that are increasing in size and number and often have a dark color. So here's an example in that image of what floaters might look like, and they'll often be moving across the vision. So that's an indication to go and see your eye care professional urgently if you get a sudden onset of floaters like that. So if someone develops proliferative diabetic retinopathy, which is the development of those abnormal blood vessels which are starting to grow from the retina, that's usually the threshold for commencing treatment. And the very best and most effective treatment we have at the moment for a proliferative diabetic retinopathy is laser. We've been doing laser of the retina for more than 50 years now, and it remains a highly effective treatment. The laser treatment is administered in an ophthalmologist's clinical rooms at a specialised lamp. It looks a bit like the standard slit lamp, but it's got a laser device on it. Usually you'll have a drop of local anaesthetic administered and a little contact lens placed on the surface that helps to focus the laser light. Laser spots are administered to the retina, usually over about 2 to 4 sessions, often a few days or a week or so apart. And those laser spots mean that, that anywhere that's been treated allows more oxygen and nutrients to get through. And we treat the more peripheral parts of the retina so that we can protect the macula, the area of the retina that's most important for vision. So we know that treatment results in a halving of the risk of severe vision loss in 5 years. So if we had someone with early proliferative diabetic retinopathy and we didn't treat them with laser, they would have twice the chance of developing severe and irreversible vision loss at 5 years. So it remains a very important treatment. What about macular edema? Well, macular edema is now largely treated with injections into the eye. These are tremendously effective in most cases, but do require repeated treatments. So we mentioned at the start of the talk that the growth of these abnormal blood vessels and the leakage from the existing blood vessels is caused by a number of chemicals. And the most notable of those is this growth factor called vascular endothelial growth factor, which the retina makes when it's not getting enough oxygen and nutrients. So vascular endothelial growth factor, or VEGF, is the target of these injected treatments. Some common treatments in that class include Eylea or Lucentis. Those are the commonly used names. And they're given as injections that are used as often as every month into the side wall of the eye. It sounds quite frightening, but it actually is quite a quick and simple procedure that's done in the consulting room of the ophthalmologist. And most people don't find it too uncomfortable at all. It's done with a local anesthetic drop and some cleaning solution, and it's usually done quite quickly. So those anti-VEGF injections result in resolution of the macular edema and often a significant improvement in the vision. Some people don't respond very well to the anti-VEGF injections, and so there are second-line treatments, anti-inflammatory medications that can be injected into the eye as well, and these are steroid-type medications. There are certain people in whom steroid medications are not recommended, and so your ophthalmologist will be able to discuss with you which is the most appropriate treatment. So I think this is quite an apt image to describe the treatment journey that you embark on when you have macular edema. You are on a long and sort of winding road. There are going to be many visits to your ophthalmologist, usually monthly for say 6 to 8 months. And then over time, the interval between injections can extend. And most people are able to wean off those injections altogether after about 2 to 3 years at most. And most enjoy very good vision as a result. So the outcomes are great, but it is quite an endurance event. And so you need to be aware of that at the outset of this treatment. When we focus on treatment, it's always important to re-emphasize that maintaining blood glucose, blood pressure, and cholesterol within target ranges is still very important. So even those people who are getting laser injections will still benefit from taking good control of those risk factors. So just before we move on to questions, I thought I'd provide you with a brief introduction to the Keep Sight program, which is very close to my heart. So we started Keep Sight in 2019 to tackle the problem that almost half of Australians with diabetes are not getting their eyes checked at the recommended frequency of at least every 2 years. And so we got together with support from the Commonwealth Government and some private sector partners to develop this national program to ensure people get their eyes checked when they need to. It's managed by Diabetes Australia, which is the group for people with diabetes. And you can sign up to Keep Sight either directly via our website at keepsight.org.au, or more commonly, people are signed up to Keep Sight by their eye care provider. So what is Keep Sight? Well, essentially, it's a convenient reminder that you get when your next eye check is due. So, and that can be provided either via SMS, email, or mail. And between times, you can get eye health advice via Keep Sight. There are all sorts of functions, useful functions on the website. There's information about diabetic eye disease, but there's also the opportunity for you to make a booking at an optometrist near you. So there's this find an eye care provider that we'll go through in a minute in a short video that allows you with a few simple clicks to find an optometrist near you and actually book an appointment. So Keep Sight, as I mentioned, was started in March of 2019. And since that time, we've had 175,000 people in Australia that have registered for the program. We've seen almost 250,000 eye checks recorded since that time, and more than 55,000 reminder messages have been sent by Keep Sight. And our feedback is that these reminders are most helpful and certainly most welcome by the recipients. We are just about to embark on a campaign to notify 750,000 people on the National Diabetes Services Scheme registry, inviting them to join Keep Sight. And so you might receive an email, SMS, or mail inviting you to join Keep Sight if you have diabetes and you're registered with the NDSS. But you might also notice digital advertising and billboards and so on, advertising on trains in the coming weeks. So this is a very brief highlight, a short video to highlight the KeepSight website. So it's keepsight.org.au. You can scroll down, there's all sorts of information and stories. You can click that Find a Provider link at the bottom left, and then you can enter either your suburb or your postcode, and you can find all of the optometrists located near you. There's then the opportunity to click on the link for the optometrist that you're interested in seeing, and that will take you to their website where you can directly book an appointment. You can see appointment availability, and in a few clicks, you can actually make your appointment for your eye test. We know that one of the barriers to getting regular eye checks is just the big juggle of managing various health priorities, and the fact that it's often on the to-do list and it often gets bumped down. So this Find a Provider provides a really convenient way to make sure that you get your eye checks when you need them. So you can just see that process is a matter of a few simple clicks, and you can book that eye test in. So just before we turn to the audience questions, I'll just address some of the common concerns and misconceptions that I hear as an eye health professional. So one common one is, I don't get regular eye checks because I can't afford it. That's quite a concerning one, because diabetes eye checks are usually bulk billed to Medicare. So it's important to check with your optometrist when you're booking an appointment to see that there are no out-of-pocket costs. And you can usually find an optometrist that will provide you a bulk billed diabetes eye check. Another one that I commonly hear is, my vision is fine, I don't need an eye check. And that gets back to that common misconception, is that you just need to wait for symptoms before you get your eye check. We know that the diabetic retinopathy can progress to quite an advanced stage without symptoms. And so you really need to have that regular schedule of eye checks to make sure that you're detecting the disease at a time where you need treatment, and getting in there before your vision is affected. So the other side of that coin, and I often have heard this, is, I have blurred vision, so there's no point getting checked because nothing can be done. Well, even if diabetic retinopathy has affected your vision, you're still likely to get a good outcome if you present earlier, rather than just accepting it as inevitable that you're going to lose your sight. We have got these highly effective interventions nowadays, and we really can make a difference. But the sooner you get in and the sooner you get the treatment you need, the better the outcomes for vision. It's common to hear that people are afraid to know if they have diabetic eye disease, and so they prefer not to get a check. Again, I would sort of emphasize that a simple eye check, a quick eye exam often will provide you with reassurance. And if there is early diabetic retinopathy, you can get treatment before it becomes advanced. And of course, we've heard several times during this webinar that there is a lot that can be done about risk of diabetic eye disease through screening, but also through managing those modifiable risk factors. So you can find help through the Macular Disease Foundation website. There's plenty of information. You can sign up to webinars like this one today, or register for informational newsletters. And of course, there's that tremendously helpful call line, the helpline on 1-800-111-789, where you can speak to someone and get advice and be pointed in the right direction. The KeepSight website, which is keepsight.org.au, has useful information, and you can register for your eye check reminders. And the Diabetes Australia website at diabetesaustralia.com.au also has information about diabetic retinopathy, but around every aspect of managing diabetes. And of course, your eye care provider is your ally and will be a great source of advice and information for you about diabetic eye disease. So that has been a whirlwind tour through diabetic eye disease. I will now hand you back to Delaney, and I welcome your questions.
Perfect. Thank you so much for that, Peter. That was extremely informative and fascinating. And I, for one, definitely learned a lot from that. So thank you so much. Before we get into questions, I might just give everyone a quick reminder on how they can ask those questions. So again, there is a black bar at the bottom of your screen. In the middle of the the middle of the black bar will be some icons. The third one will say Q&A. So that's the one with a couple of speech bubbles there that I've circled in the red. And then once you click that, the white box will appear. You can pop your question in at the bottom and then select send. Okay, so before we get into that, I quickly wanted to go over the pillars of the Macular Disease Foundation Australia. We have a goal to try and reduce the incidence and impact of macular disease, and we try and do this through our 4 pillars. So our first pillar is prevention and early detection. So we provide current, accurate and ongoing information to try and increase the awareness of macular diseases nationwide. And last year we reached over 7,000 people through our education sessions. Support and services. So we provide support for the entire macular community, and we also facilitate support to other services. I'll talk a little bit more about this in a moment. Thirdly, the voice of the macular disease community. So it's our privilege to advocate for the best interests of the macular community, whether it be designing policies for state and federal governments or making sure that medical benefits are not cut. And finally, research and data. So 100% of funds donated to our research go directly into our research grants program. Since 2011, we've donated a massive $4.1 million to 21 different research projects. Now, this is how we can provide support for you. So I know I've said this number a couple of times. That's our toll-free national helpline, which is 1-800 111 709. So if you have any questions, not just about diabetic eye disease, but perhaps about age-related macular degeneration, perhaps about government services such as NDIS or My Aged Care, or even something simple as transport for you to get back and forth from your eye appointments, those are the sorts of things that we can help you out with. If you prefer to email us, you can do that as well. You can email us at education@mdfoundation.com.au. You can also go onto our website for further information, which is www.mdfoundation.com.au. Now, at the end of this webinar, we will be sending you an email. That email will contain a couple of different links. The first link will be to a feedback survey. If you could fill this out, that would be really great. It just provides us a little bit of feedback on how we can improve for future sessions and how this session went. It also will provide a link to some resources. So we have a couple of resources around the webinar today. One is called Reducing the Risk of Diabetic Eye Disease. The other one is called Living with Diabetic Eye Disease. If you would like some of these resources, you can click on the link and order that. We will also send a link to a list of our previous webinars, which have been recorded, and you can watch those in your own time. And we will also send yet another link. This is for a list of future webinars that we have coming up. And speaking of future webinars, our next one is going to be all about understanding mental health and coping in vision loss. It's going to be presented by Dr. Bonnie Sturrock, and it will be on Wednesday, the 25th of August from 2 to 3 p.m. Australian Eastern Standard Time. If you would like to register for that, you can email us at education@mdfoundation.com.au to register. Perfect. So it looks like we do have quite a few questions coming in, so I might go through those. Thanks, Peter, for sticking around to answer the questions. So the first question I have is, if you have gestational diabetes, can you get diabetic eye disease?
Yeah, so that's a very important question. So people who develop diabetes during pregnancy, so-called gestational diabetes, usually it's a short, limited episode of diabetes during pregnancy and sometimes in the post-pregnancy period. they are not, those women are not at risk of diabetic retinopathy during that time, and they don't need eye checks during the pregnancy, as opposed to women who have diabetes before they become pregnant. They need to have the eye checks during pregnancy. I would just qualify that a little bit further, because gestational diabetes, we know, is a risk factor for later type 2 diabetes. So anyone who has a diagnosis of gestational diabetes should be followed in the longer term to check that they're not developing type 2 diabetes.
Right, perfect. And I think that sort of leads on to the next question we have, which is what type of diabetes is most likely to get diabetic eye disease? So type 1 or type 2?
Yeah, so I mean, it's a challenging question. I think the take-home message is that both types 1 and type 2, the main types of diabetes, are at risk of getting diabetic retinopathy. We know that people with type 2 are likely to have signs of diabetic retinopathy soon after or at the time of diagnosis, whereas people with type 1 don't tend to have it at diagnosis because it's a more precipitous onset, but over time are more likely to develop retinopathy. So both groups are at risk, and people with type 1 and type 2 should get regular eye checks.
Perfect. So this question is around treatment. Is laser or is injection treatment used more often in diabetic eye disease?
Yeah, so again, another really great question. So about 10 years ago, before we had injected treatments, the mainstay of treatment for both proliferative diabetic retinopathy, which is the growth of those abnormal blood vessels, and macular edema was laser. We know now that the injected treatments are much more effective for macular edema. There are some instances where macular edema, but not affecting the very central area of the vision, can be effectively treated with laser, and that's still a highly effective treatment. But the mainstay for macular edema is now injected treatments with these anti-VEGF medications. Although some people use those injections as well for proliferative diabetic retinopathy, the main treatment for proliferative is laser. So laser for proliferative disease and injection for macular edema is the most effective at the moment.
Perfect. Another question. So this person says, if I've been diagnosed with diabetes, should I see an eye specialist straight away, or should I wait for the 15 plus years?
No, and again, that's a very important clarification. So anyone who's diagnosed with diabetes should go and see an eye care provider, and that's usually in the first instance an optometrist soon after they're diagnosed. That is particularly the case for people with type 2, but it's a good habit of just soon after diagnosis getting a check with an optometrist.
Perfect. So this is going back to macular edema. If I have macular edema, will I always have swelling, or can it go down? I'm assuming they mean with treatment there.
Yeah, it can wax and wane even without treatment, but we know that once you have got macular edema, it does tend to stay for many, many months, and untreated can progress and can be associated with permanent vision impairment. So if you have macular edema and it's affecting the vision, so you've got reduced vision on a vision test, then there's strong evidence that your best long-term outcomes are from having injected treatments with the anti-VEGF agents.
Right, perfect. This is, I think, to do with genetic links. So is diabetic eye disease hereditary?
Again, quite a nuanced question. For most people who have diabetes, there is a risk. So everyone with diabetes is at risk of diabetic eye disease. We do know that some people tend to get diabetic eye disease earlier and more aggressively than others. We don't yet understand why that's the case. We certainly know that variations in blood sugar control, blood pressure and cholesterol can influence the rate of progression. But even so, some people are at higher risk, and we don't yet know why, and it's probably influenced by genetic factors.
Right. And I think last question for today, I might actually combine two questions here. So do I have to receive photos or have photos taken of my retina at every appointment? And do I need to pay for these?
Right. Okay. So again, it gets back to that question of having a discussion with your optometrist in advance of your appointment. Photographs are usually a part of the standard diabetic eye disease consultation and usually don't attract a fee. Some optometry practices may charge if they do an optical coherence tomography scan or OCT scan, that thickness map of the back of the eye. Again, other practices may not. So it's a case of just finding out if you have concerns about that in advance of the consultation, and you will be able to find a practice that does not charge. So do a bit of shopping around, but I would say that the best outcomes for your eye health are finding an eye care provider that you have a therapeutic relationship with and return to over time, because they'll be best placed to see if things are progressing.
Definitely. Well, Peter, thank you so much for being with us today. I think everyone that's listening definitely learned a lot. So we really, really appreciate it. Thank you very much. And thank you everybody also for joining as well. And hopefully we'll see you all at the next webinar. Thank you so much. Thanks, Peter. Thank you.
Bye.